coming to the last 3 talks, I think so. So this will be one of my SPECT-CT in infection imaging. Infection often represents a major diagnostic challenge. This is a slightly smaller talk. I'm not going to go in detail about the tracers and other things. So diagnosis and precise, because it helps more in terms of localization. And as we know, we have a range of diagnostic radiological and radionuclide techniques available to assess patients with infection. And structural changes seen on the CT and MRI may be quite non-specific, and therefore often we get a request for radionuclide bone scan to exclude infection in patients. So in patients again with disturbed anatomy or post-surgery, it is quite challenging to say whether there is disease. And in patients with metallic implants, the image quality on the CT or MR can be relatively poor because of artifacts due to the metallic implants. Immunosuppressed patients, changes seen on the functional imaging may not represent what we see on the anatomical imaging, so which may be abnormal only during the recovery phase. So what are the common indications we do SPECT-CT is when you have a suspected bone or a soft tissue infection, and if they want to just to differentiate soft tissue from bone infection. Assessment of diabetic foot, although our center is not a regional center for this, it's done in another hospital. And the fever of unknown origin could be another good indication, but the current evidence in infection imaging, if you have a patient with fever of unknown origin, FDG PET scan is the imaging choice. So if you think the patient is there in quite a long time, it's ideal to go for a PET-CT scan rather than a white cell scan and delay the diagnosis. Vascular graft infection, again, the role of SPECT-CT is changing. More and more people are going for a FDG PET because you get the diagnosis within a day rather than doing a white cell scan, which take a few days, and added with all these marrow changes and all sorts of things. And for miscellaneous indications, if your bone scan is equivocal or a white cell scan is equivocal for infection, then it's best things to have a correlating imaging to differentiate bone from soft tissue pathology. Major role, as I said, differentiating between soft tissue and bone, assessing suspected infection sites underlying the bone alterations, defining infective focus whenever there is a complex anatomy, and all these 3 areas nuclear medicine can be useful. Current evidence, this is a current evidence looking at the value of SPECT imaging and SPECT-CT in patients with infection and inflammation. And in fact, by using SPECT-CT showed higher specificity than MRI, but in terms of sensitivity, MRI is definitely more sensitive than nuclear medicine techniques. This is another paper from Hojer et al. Who's done quite a lot on bone imaging, but he has reviewed added value of SPECT-CT in patients with suspected bone infection. And in their paper, they said that by adding SPECT-CT, they improved specificity of about 86% compared with, if you do just the SPECT, your specificity is around 50%. But adding the CT bit to the SPECT component, you increase the specificity to about 86%. And in fact, SPECT-CT helps to make an alternative diagnosis, and that's where we are useful rather than just saying it is infection. And one of the major papers and one of the first papers in the SPECT-CT infection imaging, this is highly quoted paper, the role of SPECT-CT in using gallium and indium labeled leukocytes in this case for diagnosis of infection. This comes from Israel. And the main advantages they said was it is useful to assess precise localization for an area of focal uptake on the planar and SPECT, and also to assess the extent of the disease in these patients. And in fact, SPECT-CT was reported to be more accurate than planar and SPECT for both diagnosis and localization in half of their patients. So they do quite extensively in Haifa and other places in Israel. This is the standard modality, but for pyrexia of unknown origin, I think people should use FDG rather than any SPECT tracers. Another paper, this is more like a review article, and they have assessed quite a lot of patients, and again it's the same thing. They come as SPECT-CT help to make final diagnosis in about a third of patients accurately. In about 36% of the group, SPECT-CT will help to make a definitive diagnosis, to delineate, and also to assess the extent of pathology. Lose connection. Coming to this is a patient who had shoulder pain, and this is a white cell scan. And if you could see, there is increased uptake in the soft tissue in the muscle area. The clinical question was whether the patient has got septic arthritis or osteomyelitis of the shoulder. But by doing the SPECT bit, all you're seeing is the increased uptake around the periphery. By using the CT component, you can see the entire uptake is in the muscles rather than in the bone. So scan appearances are strongly suggestive of infection of the right upper arm, corresponding to the subacromial and the subdeltoid bursa. And the main question is, the clinical question was whether the patient had osteomyelitis. In this case, there is no osteomyelitis, it was just a soft tissue infection. Another patient, the clinical question was whether the patient, again, they will ask often for osteomyelitis. The white cell scan showed a focal uptake in the medial aspect, and on the SPECT-CT scan, we could see a small nodule lying on the lateral aspect. Even correlated with the recent MRI, you can see a posterior medial aspect, and scan shows a nodule along that, and that's where the infection is. So from bone, we have changed the diagnosis to soft tissue infection in this patient so that we are more accurate in terms of localizing. Another patient with previous episodes of osteomyelitis, the question was whether this patient has got osteomyelitis once again. And if you see on the white cell scan, there is increased uptake on the lateral aspect of the tibia, which on the delayed images also shows increased uptake, but on the SPECT-CT, it is not in the bone, it is on the lateral aspect of the soft tissue. Therefore, we can differentiate osteomyelitis from soft tissue infection, and SPECT-CT was useful in this to exclude osteomyelitis, and this was just a soft tissue infection. This is a patient I showed yesterday. She's a young patient with back pain. First, she was referred to physiotherapy, and they did an X-ray, and the physiotherapy specialist was not happy to go ahead with the physiotherapy. He asked for a bone scan, and the bone scan showed linear increased uptake, classical for a fracture. So that's what we would have said, because the patient's got pain. But the only thing is she was an Afro-Caribbean with back pain. She was around 35 to 36 of years, so our suspicion was whether this patient must have tuberculosis. So in this case, we had SPECT-CT done. As you can see, there is destruction of the L2 vertebra, and also there was a psoas abscess adjacent to this region, and a diagnosis of osteomyelitis was made on culture basis. So we raised a possibility of osteomyelitis because of the age and the ethnicity, and also it's very rarely to see a 35-year-old having a vertebral fracture unless she is severely osteoporotic or something like that. Another patient who had a renal transplant, and the question was whether this patient has got a rejection or infection of the transplant. And also this patient also had what is called as a gastric pull-up surgery, so they do it for the procedure. And when we did the white cell scan, there was a focal uptake in the lung. The clinical question was where exactly it is, because they were asking whether the patient had any infection to the lung, to the renal, the transplant kidney. The transplant kidney looks relatively fine. So in this case, the increased uptake is in the lung. It was a huge consolidation, and that was the source of infection in this patient. So what has happened in this patient is, because of the gastric pull-up surgery, the patient must be aspirating quite a lot, and that is the cause for the infection in this patient. So we excluded renal infection, and definite source of infection was found on the planar, as well as we could localize exactly to the lung on the SPECT-CT. Another patient, in this case it is a straightforward one, but only thing is you get a better anatomical delineation using the CT component, where there is quite a lot of destruction, sclerosis, increased vascularity, increased uptake in a patient suspected with osteomyelitis. But without the SPECT-CT, I could have said this is osteomyelitis, but for a better delineation for exactly how much is involved, it's better to do the SPECT-CT and say whether it's a proximal or the whole third, upper third or upper half, and all sorts of things. We can give a definite anatomical correlation, and that's where SPECT-CT helped in this patient. Now the patient, septic arthritis of a lumbar facet joint. This would have been a classical one, severe back pain, and patient had fever and other raised blood parameters, and he showed a classical increased uptake on the bone scan, and on the SPECT-CT you can see there is a destruction of the joint, and also there is increased intensity on the MRI, which fitted with the diagnosis of septic arthritis of the lumbar facet joint in this patient. Osteomyelitis, this is again a classical case. Patient had increased uptake both at the early phase and the delayed phase. But on the SPECT-CT, you can see there is a huge defect where there's quite a lot of bone destruction, and because it's not inducing any blastic reaction. But on the SPECT-CT, you can see there is increased uptake only towards the periphery. Therefore, it helps in accurate localization and also to assess the extent of disease. Patient who had sternotomy and there was increased uptake persisting even 3 months after the surgery. The patient had persistent pain, and we did a 3-phase bone scan, and bone scan showed increased tracer uptake and vascularity. But again, this is commonly seen in post-operative scenario because it can stay up to 6 months, or sometimes in patients up to 1 year we see linear uptake in the sternum. But by doing the SPECT-CT, you can see the focal uptake, especially the lower focal uptake, it's not projecting well to a small abscess in the region of the sternum, and that was said to be the infected site in patients. So advantages of SPECT-CT, because it's a smaller talk, I just want to say SPECT-CT is useful, and you can use it whenever there is a problem in terms of localization, if you want to assess the extent of disease, differentiate bone versus soft tissue infection, and that's where we have a major role. That's what I would say, because in all other indications, if it's a pyrexia of unknown origin, if the patient is an inpatient, if they ask for a white cell scan or anything like, I would refer them back to have an FDG scan, because it gives a better diagnosis. Do a whole body bone scan, inject in the morning, and you can get the report in the afternoon or in the evening. So rather than drawing up the blood, labeling it, injecting, it all complicates the entire scenario. But for bone pathologies, again, we should stick, because there is evolving evidence of role of PET-CT in infection and inflammation, including prostheses. But for the time being, yes, if it's a bone infection, we should stick to white cell scan plus or minus SPECT-CT.